Good morning, everybody. Thanks for joining us for today's Q&A. We are giving media recording permission, so just bear with us for just a moment. Today we have Dr. Jeannie Marazzo, Director of the UAB Division of Infectious Diseases, and Dr. Claudette Poole, Associate Program Director for Pediatric Infectious Diseases with UAB and Children's of Alabama. Today they'll be discussing the downward trend in COVID hospitalizations, while at the same time the increasing surge of influenza cases and RSV in Alabama and nationwide. As a reminder, we are sharing this live stream on the UAB Facebook page, and we'll be providing a recording to media shortly after. For media, if you have questions, please use the raise hand function in the expressions tab or reactions tab, or submit them through the chat. If you're on our Zoom stream, please mute your lines until we're open for questions. We'll also try to answer a few questions from Facebook if we have time. So to begin, Dr. Marazzo and Dr. Poole will provide a few thoughts, and then we will get to your questions. So Dr. Marazzo, we'll start with you, and then we'll go over to Dr. Poole.
Sure. Thank you so much, Adam, and thanks to the media folks who are here. I'll give a very brief background of where things are at, and then I'm going to turn it over to Dr. Poole to round out the discussion, given her pediatric expertise. So if you look at the COVID situation overall, it's probably pretty apparent to most that we are in a pretty good place. Both deaths and hospitalizations continue to decline, as do the number of cases, although, as you know, the number of cases getting an accurate estimate can be really challenging. And just one caveat, we still are seeing about 350 deaths a day in the United States from COVID. So this is by no means over, but if you look at the meta trends across the United States, they actually are looking very encouraging. Why is there caution, and why are we doing this press briefing today? We've talked a lot about the emergence, of course, of different variants, and they're driving sequential waves of various aspects of how the virus has played out, right? We had the Delta wave, and then we've most recently been getting through the Omicron wave. And just one quick reminder about the science of variants. The way that variants give us trouble is largely through the way that the mutations change the part of the virus that binds the antibody, okay? It's called the receptor binding domain. If the antibody that either we make from natural infection or that we generate as a result of the vaccine can't bind at that part of the virus, then the antibody can't protect us. So what we're always very concerned and worry about with variants is not just that they can be more infectious, like Omicron clearly was, not just that they can cause more severe disease, like Delta clearly did, but also that there is a component of what we call immune evasion. And that is essentially what we're talking about when the antibody can't bind. I'm going into that in a little bit of detail because what we're seeing in the surveillance of the variants is just in the last month or so, a gradual decline in the Omicron variants that have driven the most recent surge, BA4 and 5. They are now down to around 70–75% of the variants that we're seeing across the United States. And unfortunately, what appears to be replacing them are a couple of lineages or variant family types that could pose a concern with regard to this immune escape. I'll just mention a couple because, as usual, it's sort of like alphabet soup, so I don't expect anybody to remember them. But a couple that you should just keep your eye on, there's one called BA275. We know that that already is rendering some things that we use for treatment and prevention ineffective, particularly monoclonal antibodies. There's one called Evusheld that we have used to give people, for example, transplant patients, other people who can't make a great response to the vaccine actually can get that monoclonal, and that will protect them from infection. Unfortunately, it looks like Evusheld doesn't work with this variant. So that poses a very significant risk, unfortunately, for our most vulnerable patients. So that's kind of worrisome. There are a couple of other variant families that look also rather scary. I'll just mention them. There are the BQs and the XBBs. Why are we worried about those? So when you start to use different letters entirely from B and go all the way to X, that's a way to signal that these viruses are even more different in terms of their potential for immune escape. Those viruses are playing out now in Southeast Asia, particularly Singapore. They may become increasingly dominant in India. And if that happens, we may see a surge of variants that are not going to be necessarily as responsive to immune protection. So again, not to be fear-mongering at all, just to remind people that we do have to be vigilant, and vaccination with the current booster that we have now, which is targeted to that BA.4/5, likely will help mitigate or help prevent the most severe outcomes of COVID, regardless of what lineages are coming down the line. I know that I said it might not work as well, but we think there still will be some effect for severe disease. And after all, that's what we really, really care about. So my first message is, if you haven't gotten that last booster, I would strongly recommend as we go into the winter that you do that. So that's pretty much the COVID situation. One thing to add to that is that we don't yet have evidence that Paxlovid, which is the pill that we use to treat COVID, is not effective against these new variants. It's very possible that Paxlovid will continue to work. It has a different mechanism of action. So I would encourage you to be sure that you know Paxlovid can be available. Not everybody can take it. There are a lot of drug interactions that you have to be very cautious about, but really important to know that that's a great option to treat COVID, especially if you treat it early. So, and then with regard to where we're at UAB, just to give you a sense, our numbers of patients who are hospitalized with active COVID are now down into the very, very low double digits, which is pretty remarkable. And one of the reasons we wanted to talk today, it's a real testament, I think, to the work that's been done in our communities to protect people and be vigilant. I will say, though, going on to my second topic, and this informs this new phrase that I've heard called the triple-demic, which means that this winter we may see not only these COVID variants causing trouble, but also influenza and RSV, or respiratory syncytial virus, which I'm going to turn over to Dr. Poole to talk about, given her pediatric expertise. So let me just say a couple things about the current influenza situation. I mentioned that we have COVID patients in the double digits at UAB. We have about the same number of patients with influenza hospitalized at UAB. It's a little bit earlier than usual, and there seems to be a higher number of cases for this time of year. And that's worrisome. It's very much parallel to what Australia in the Southern Hemisphere, they just finished their winter, and what their flu season experiences is often what our society experiences in the Northern Hemisphere in the subsequent seasons. They had a very tough year with influenza, lots of cases, lots of hospitalizations, and early onset. So I'm hopeful that that isn't what we're going to see, but I do think it's possible. We don't know yet how effective this year's flu vaccine is going to be. One thing that people have been bringing up is this concept of a loss of pandemic, quote unquote, immunity, or an immunity gap. And I want to just address what that is. Basically, it means that if you haven't been out and about in the last 2 years, you've been masking, you've been home, kids in particular, as Dr. Poole will discuss, haven't been in daycare, people haven't been in schools, you haven't been exposed to all the viruses that usually circulate in the winter. And if that's the case, your body hasn't had the chance to really react or to create antibodies to them. So there is a theory that we as a society, as a community, may be more vulnerable right now to the usual winter respiratory viruses we see. And that may be even more important for younger people, particularly kids. So another piece of advice: get your influenza vaccine if you haven't had it yet. So I think if you can really want to tee up to be as protected as you can for this season, getting that COVID booster as well as an influenza vaccine, probably your best bet. And I'm going to turn it over to Dr. Poole to discuss the third virus, which is the RSV situation.
Great. Thank you, Dr. Marazzo. I don't have a huge amount to add to that, just that, as most of you are aware, COVID has not been particularly problematic for children in terms of driving hospitalizations. And during the pandemic, children's hospitals overall actually experienced lower census because we weren't seeing the usual circulation of the viruses that do cause hospitalization in children, and that includes influenza and RSV. So now that society has gone back to, activity that really is normal, we have to go back to school, we have to go back to work. These viruses are now allowed to spread in our community. And as Dr. Marazzo alluded to, we haven't really seen it for the last 2 years. And so we're playing a bit of catch up. So children who normally would not get severe symptoms with their influenza or RSV because they had their more severe illness in the year prior, we're now seeing a sort of double volume of children who will be exposed, who will get symptomatic and will present to healthcare. RSV season typically starts in October and will run all the way through to March. And the same is true for influenza. I think what may be a little bit unusual is that we're seeing a pretty steep upward surge in these viruses early on in the season, which does give everybody a little bit of pause that this may be a sort of long winter of a lot of illness. And with that, I will stop and hand over to questions.
Great, thank you. As we're waiting for media to submit questions, we do have a couple of questions that were submitted already. This could be for either of you. After all the breakthroughs with COVID vaccines, how come there is no vaccine for RSV? Are there trials? What update can you provide there?
Yes, and that's the $1 million question. There's been a long history in trying to come up with a effective RSV vaccine. Unfortunately, to date, there has been no successful vaccine brought to market. So I think contrary or maybe in parallel to the coronavirus, RSV is one of these viruses that we do not develop lasting immunity to. So as adults, we can continue to get the same RSV infection year upon year. It just does not cause significant symptoms. So it's a mild cold-like illness, lasts a couple of days and is over. It's usually young children, medically fragile individuals, and the elderly that are more at risk of developing severe disease. So yes, there is a lot of work going into developing an RSV vaccine, but unfortunately to date, none have been successful. So we do not have a vaccine for RSV. We also don't have any effective therapeutics. So Dr. Marazzo was referring to Paxlovid, which is an antiviral that treats coronavirus. In the terms of influenza, we have effective antivirals, oseltamivir, or commonly known as Tamiflu, and a newer antiviral on the market called baloxavir or Xofluza. Both are super effective if used early in the course of illness. We do not have an antiviral that is effective against RSV.
All right, thank you. Dr. Marazzo, you mentioned the bivalent boosters and who should be getting it. Is there a timeline on when someone should get it after they've received a previous booster?
That's a great question. And the related question is when they should get it after they've had a COVID infection. Most people would advise waiting probably about 3 months. You could go a little bit longer if you want to, but in our sort of evolving understanding of how long antibodies and the kind of antibodies you really want last in both the setting of natural infection and immunity, by 6 months, people are pretty much done. There's almost nothing there to protect you. And that's exactly why, as Dr. Poole said, with RSV, you get infected with these viruses every year, just like coronavirus and the common cold. So by 6 months, you're really pretty vulnerable. By 3 months, you see a significant decline to the point where you might not have enough to really protect you. So start thinking about it at 3 months, but any time in that window, 3 to 6, is a great time to do it. I would definitely do it before 6.
All right, thank you. This question comes from Facebook. What combination tests are available for flu and COVID? And maybe possibly one of you may be able to comment on the Alabama hospital situation with RSV, COVID, and flu.
Claudette, do you want to address that for kids? Because that would be more likely, I think the testing would be more likely to occur there for all 3.
Yeah, there is plenty different testing platforms available, both rapid sort of diagnostics that are available within 30 minutes, and there are PCR assays. So there definitely is not a shortage of assays available to be able to test patients for all 3 viruses simultaneously. And they're very reliable and very accurate.
All right,
And
thank you.
in terms of the, so it's okay, in terms of the Alabama flu situation, I'll just mention that when you look at the United States National Flu Surveillance Map from the Centers for Disease Control and Prevention, we are in a very hot zone right now. So Texas in particular was in the red just a few days ago, and the swath of places reporting the highest numbers of confirmed flu cases are really in the Southeast, which is interesting because it's a little bit different from what we have seen with COVID. A lot of the new variants and the high cases often start in the Northeast, the upper Midwest. Here we really are in a hot zone. Georgia, Texas, a little bit higher numbers than us, but I think we're rapidly catching up. So there is variation nationally in the numbers of flu cases, but I think it's just a matter of time before other places catch up to us.
All right, thank you. Dr. Poole, you mentioned a little bit about RSV immunity. Is there any evidence that RSV immunity is similar to COVID? So if your child had it in late summer, can you have a concurrent infection?
The short answer is yes. RSV immunity does not last. Typically we'll get RSV annually, so it would be highly unusual to get RSV twice in a year, but not unheard of. And the reason you get it annually is because of the fluctuation in circulation of the virus. So typically RSV is very active in the winter months, and then it goes down to a very low activity level during the summer months. I'm sure most of you on this call are aware that we did have a spike, though, of unusual RSV activity during the summer months. So this may be the year where we're going to see patients getting RSV twice.
Thank you. Dr. Poole, we'll stay with you. What should parents or caregivers be looking for when it comes to RSV? What types of symptoms? And then what symptoms would present that would warrant going to the ER?
Sure. So, RSV starts off as just a simple upper respiratory infection or the common cold. So runny nose, sore throat. It can be associated with fever, typically not very high fevers, and can cause a cough. The cold phase of this virus should last no longer than a week, 10 days at most. The issue with RSV is because of all the congestion, it can lead to secondary infections, the most common being an ear infection. So I advise families with younger kids who are more prone to ear infections that, as your child is recovering from their cold and then the fever seems to come back, or they have difficulty sleeping, or they're crying with ear pain, that is the reason to go to your healthcare provider to check for ear infections. It can lead to sinusitis, but that's usually a sort of later sequelae. So you're busy recovering from your bad cold that's lasted a week to 10 days, and then you just start feeling ill again with worsening congestion, headaches, fever, another reason to go see your healthcare provider. In the younger age group, and this is typically children less than 2 years of age, RSV can settle in your lungs and it can cause a wheezing type of illness with difficulty breathing. And if your child is struggling to breathe, so in babies, the markers for struggling to breathe is if they're having a hard time feeding. Those would be the indications when I would say, okay, now it's time to take your child to the emergency room if your doctor's office is not easily accessible.
All right, thank you. We had a slight technical issue with Dr. Marazzo's video feed, so we'll get her back in just a second. But Dr. Poole, maybe you can comment if we're seeing a wave of so many RSV or flu cases now, is it fair to think that we may be getting the worst out early this season? How does that forecasting work?
It's that I think only hindsight will be able to tell, right? So I'm not sure. I'm not sure what to predict. I don't want to predict what it's going to look like. I know a lot of experts around the country were warning that we would probably see a sort of severe influenza season, meaning lots of people contracting symptomatic influenza that would drive the need to seek out healthcare. That is what we're expecting. We're expecting that we're going to see a lot of cases, and a lot of cases actually requiring visits to the doctor or visits to the hospital. And we're anticipating sort of an increase in hospitalizations for influenza as well as RSV this season compared to the prior 2 years. And that's especially true for the Children's Hospital. But how long it's going to last, only time will tell.
I'm not sure if you can you guys hear me and see me?
We can hear you. I can't
Oh.
see you.
Okay, well, you don't need to see me, but let me just add on to that, to Dr. Poole's comment that, there were several articles yesterday, particularly in New York City's very much seeing an increase in hospitalizations for influenza. So I think, and again, our somewhat early numbers, although they're still low and hopefully will remain low, I think, again, I don't love predictions either, especially when it comes to viral respiratory infections. But I think it's a fair bet that if we follow the Northeast in particular, we may see a surge of hospitalizations for flu this year. The one thing I will say, and I would love Dr. Poole's thoughts on this, so far the surveillance would indicate that this is an influenza type A epidemic. And if there's any silver lining about that, we do know that a couple years ago, pre-COVID, we had a year where influenza B dominated, and that's particularly bad for children. And I don't know if, Claudette, you want to comment on that.
Yeah, I mean, we're also mostly seeing influenza A. I looked at our surveillance data for the last month, and almost all the cases were exclusively influenza type A. We have, however, seen a few of really severe symptomatic illness. So again, I think these viruses can be very unpredictable, and it's something we can only comment on in hindsight when we look back at what the season was like. So in terms of how effective was the vaccine, is only something we can say afterwards, how severe manifestations were. Again, I think it's something we just have to anticipate and get ready to be able to treat those children that need our care.
All right, thank you. Let's see, another question we had here. What kind of preventative measures can parents, children take to stop or slow the spread of any of these viruses? Is it one and the same when it comes to preventive measures?
Yeah, so, as mentioned, we don't have a vaccine for RSV, but we do have a vaccine for influenza. And what we do know about the influenza vaccine is it's very effective at decreasing the severity of the flu symptoms. So you may still get flu even after you've been vaccinated, but the need to actually seek out healthcare or end up in the hospital is dramatically reduced if you've been vaccinated. And the vaccine is available for ages 6 months and older. So I definitely encourage all families, if your child has not been vaccinated, to please get vaccinated. Then in terms of other preventative measures, early diagnosis of flu is important because we have highly effective antivirals. So especially again for our high risk groups of patients, starting an antiviral very early will decrease the severity and decrease spread of the virus. And then other measures is to keep your children home from daycare or school if they are sick, because these viruses spread very effectively in closed environments. It's all droplet spread, so sort of talking, coughing, sneezing on your hands. And so the best thing we can do is just stay home if you do have respiratory symptoms, good hand hygiene, and that's pretty much it.
I think that's superb advice. The one thing I would add, if you are pregnant, it's really important to make sure you get your flu vaccine for a couple of reasons. It's completely safe, so you don't need to worry about it doing anything in terms of harm to the mom or the baby in utero. But most importantly, pregnant women who get influenza have a much higher rate of mortality and hospitalization than non-pregnant women. So we know that pregnancy is a relatively immunosuppressed state, right? So the pregnant women can get sick, particularly with viral infections. So that's the first reason to protect the mom. The second is that the mom generates antibodies to the vaccine in pregnancy, and those are passed to the baby. So the neonate or the newborn actually does have the benefit of the antibodies made by its mother when she was vaccinated during pregnancy. So very strong recommendations from all of the obstetric gynecology organizations to be sure to get your flu vaccine if you're pregnant.
Thank you, Dr. Meltzer. Oh, I'm sorry. Go ahead, Dr.
Sorry, yeah, Dr. Maratha, I would strongly echo that recommendation. So if we're talking about influenza and mortality in children, the children most likely to get severe influenza and die are those little babies before 6 months of age. You cannot vaccinate a baby before the age of 6 months. And so the only way to protect them effectively is through pregnancy vaccination. So those antibodies do cross over and they are highly protective of the infant. In addition, we talk about cocooning. So all the household members in a family with a newborn should get vaccinated. Again, it really dramatically protects that baby in the household. The other advice I have is during respiratory season, if you are giving birth to a newborn, congratulations, but I would keep that baby not isolated, but I would definitely recommend limiting the number of people that come to visit and hold your baby. So for the first month of life, my recommendation is mom, dad, and maybe grandma is allowed to hold your baby. And that would greatly reduce the risk of respiratory viruses being transmitted to your newborn infant.
Yeah, and I would just add on to that. I have occasionally seen extremely young babies, like clearly not more than a couple of weeks or maybe a month old, at very crowded venues like various retail stores, and that's quite risky. And I think just would echo that trying to keep them from being exposed to these circulating viruses. Remember, you can get these viruses not through coughing and sneezing, but through hand contact, right? Or hand to nose contact. That's why we were so vigilant about hand hygiene during the pandemic. Those mechanisms of transmission are still very much operative. So really great advice from Dr. Poole.
Dr. Poole, what can classrooms or schools do to help mitigate virus spread within the classroom?
So having lots of hand sanitizer and tissues available. Children, with runny noses or coughs, if they could have tissues, lots of waste paper baskets, and lots of hand sanitizer available is very helpful. And then really to encourage children to stay home if they are symptomatic. I know there's a lot of pressure on children to be in the classroom for learning, but certainly if they do come to school sick, these viruses can spread very effectively and efficiently through classrooms. So I know I just heard on the radio this morning that some of our county schools have been closed to be able to stop the spread within the school. And that's because once the virus gets into the school community, it can just spread like wildfire.
Thank you. Dr. Marazzo, this is a two-part question for you. If you've already had the flu, how long should you wait to get the flu vaccine, or should you get the flu vaccine? And then as it relates to RSV, are adults at risk for getting infected? And what is the risk if they do get infected?
Sure, great question. So let's talk about the flu a little bit first. So if you get the flu, the first question is, a lot of people think that any respiratory illness during the winter is the flu. Dr. Poole mentioned that we have really good diagnostic tests. So if you've had a good diagnostic test and it's positive, then you should believe you had the flu. But remember that just because you have a respiratory illness that even comes with a fever, it doesn't necessarily mean it's the flu. We've talked about 3 viruses we're worried about, but there are a whole bunch more: adenovirus, parainfluenza virus, that can cause pretty significant syndromes in the winter in particular. So if you have an illness, as soon as you start to feel better, you really should think about getting the flu vaccine. There's no downside to getting the vaccine, even if you've had a recent confirmed influenza illness. You might want to wait a couple of weeks, but really it's more about making sure that you keep your antibody levels up. So you can go ahead and get the vaccine whenever you really feel better. So there's no sort of hard and fast recommendation there. The RSV question is a great one, and I think Dr. Poole alluded to it previously. We've been talking about it primarily as it affects children, and most kids, in fact, get exposed and get infected before they're 2 years old, which is why this last 2 years of limited exposure has been so concerning, as Dr. Poole mentioned. But it is a virus that takes advantage of weakened immune systems, particularly in older people. So we certainly have seen pneumonia, so bad respiratory infections caused by RSV in older people or weakened people who don't have great immune systems, particularly if they are older. The challenge with that is that we see that more when we are seeing more of a surge of pediatric infections of RSV. And that's just because, both are a reflection of the burden of disease in the community. So it's something to be aware of. And it's another reason, I think, that Dr. Poole's advice to limit exposure of very, very young infants to, in particularly older people, not just, of course, grandparents should be able to see babies, but just think about the vulnerability on both sides. So really, really think about that and know that that can happen. And I want to emphasize that there is no treatment. So when we hospitalize, especially elderly people with RSV, it's really largely supportive care, namely the things that we did early on in COVID.
All right, thank you. We haven't received any other questions, so I think we were going to end things there. Just a reminder, we will provide a recording to media shortly after this concludes. So Dr. Marazzo, Dr. Poole, thank you so much for your time, and have a great Friday, everyone.
All right,
Thanks,
thank
Adam.
you.
Thanks,
You're
Claudette.
welcome.
Bye.
Thanks, bye.
Thank you.